Good morning, and at the outset, I'd like to thank Dr. Gaurav for giving me yet another opportunity this year too to speak on this topic. I don't have any financial interest in any of the products. As Dr. Sushmita clearly emphasized, the smartphone has become an integral part of our life, and now it's becoming an integral part of our practice also. And this article published by my senior, Dr. Vinay Shah and Dr. Ken Lord, it had that time in 2010 itself, we were also had started doing these techniques, but their paper had commented on different apps, different techniques of anterior segment as well as posterior segment photographs, and also video recording in using the fundus smartphone. We all know that the fundus camera, what we have in practice right now, are very bulky and stationary, costly items. There are handheld cameras which are probably more costly. Along with that, you need a computer to transfer these images. So, why smartphones? Because we have it with us always. We carry it around. So when you go to a peripheral center, you can't carry a fundus camera along. So this is there with you all the time. And as a retinal specialist or an ophthalmologist with interest in retina, definitely you will be having an indirect ophthalmoscope with a condensing lens, either a 28 or 20 diopter lens. So the cameras right now, which come with the smartphones, probably have higher megapixels than the cameras which are mounted on the fundus cameras right now. They have video recording capability, and the more important thing is that they are connected. Any form of connections which we can think of right now, it's in the smartphone. Be it a USB connection, be it a Wi-Fi, or in case of Apple, the Thunderbolt. Any connection in the world, it is available now on a smartphone. So there's no problem. Even a 3G connection can put you across to a colleague with the images sent across for a teleconsultation. So the teleophthalmological part becomes more exciting with the smartphone and its different uses. I'd like to draw your attention to the article published by Dr. Mahesh Shanmugam, the recent IJO, which details a lot of techniques which have been used, and we also follow the current techniques what they've described. It's almost similar with certain modifications. But before that, let us see how it works as a smart fundus camera. I'm sure all of you would have at some point of time in your post-graduation tried the monocular indirect. It's just holding a torch close to your eye with an indirect lens and taking a picture, taking a look at the retina through a dilated pupil. So similarly, instead of the observer, you keep the phone. The only thing is that should be an illumination. Earlier softwares or the earlier models of phones did not have a camera option wherein you can keep the flashlight on all the time. So the roundabout way of doing that was put it onto the video mode and put the flashlight on so that you have a continuous illumination and you are able to see the area of interest when you do the fundoscopy. Now we have something called the assistive light widget for the Androids and a bulb facility in the iPhone 6. Or if you don't have it, you can go to the video mode and keep the flash on. So essentially you are doing a monoocular indirect ophthalmoscopy. And of course the condensing lens can be of your choice. We started off with 20D. Now I think I'm more comfortable with 28 diopter lens, being a smaller lens, lighter lens, is easy to handle. And the indirect comes at this level when you do indirect ophthalmoscopy. You don't have to, you can keep the phone a little more closer to the condensing lens. And the condensing lens, how you manage it is as you would do it in a normal indirect ophthalmoscopy. And you can zoom the image to the maximum so that the extraneous parts are cut off and you can concentrate on the area of interest, focus that area of interest, along with an option called touch focus. You can probably touch on the retinal blood vessels on the image or the optic disc to focus it better. Once you get the image, you can correct the images on the phone itself using the image editor, maybe the exposure, crop the images to your liking, before you can save it as a separate folder with the patient's data, and probably think of sending it across to a colleague or something like that on the email, or now we have the cross-platform messaging service called the WhatsApp. That can also be used. So it becomes a very easy thing to connect to your colleagues. I will go through a few of the pictures I've taken with the smartphone. This is taken with the Note 3. And you can see that it's almost as good as a fundus photograph. This is an optic disc pit. You can see how clearly it has taken up all the minor details of the RPE changes. This is a beaten bronze appearance in Stargard. The characteristic feature of this technique is that you have these two reflections. They are reflections from the condensing lens, and the two surfaces of the condensing lens, and it is seen in all imaging technique using the indirect ophthalmoscopy principle. This photograph can be taken. This is this photograph showing a sectoral pallor here compared to this area. This is pale. And this is a patient who underwent laser hyaloidotomy for a huge premacular hemorrhage, Valsalva retinopathy, and you can see the area of detached hyaloid, which is like a shining membrane. So those fine details are got. This is not. This is from a S3 Mini, which has a 5 megapixels camera. So you can see that even with that a low-end phone, you are able to get that kind of picture. Peripheral pictures are easy. You can. This is a acute retinal necrosis. You can see the hazy media. This is a retinal break in a myope in the periphery. This is a giant retinal tear with inversion. And post-operative also you can take. This is the first post-operative day after the surgery. Reattach the retina with a few rows of retinal laser. And this is under oil. So even in a post-operative case, you can see that this is a dropped IOL with the capsular complex in the inferior vitreous. And the most exciting thing I found is documenting retinopathy of prematurity. When I travel out to the peripheral area, it's difficult to carry anything but your mobile phone and your indirect ophthalmoscope probably. The current techniques are using a RETCAM, which is 80 lakhs or more. I don't know the real cost, but it's a very costly thing. But this gives you images good enough to consult with somebody if you need to have a consultation of that sort, or for your explaining the disease process to your neonatologist or to the parents, and to show them the follow-up. This is, you can see that this is a stage 3, and you can see the traction. You can see some amount of gap between the shadow and the retinal blood vessels. You can see the fine vitreous traction here with the retinal blood vessels growing into the vitreous, and this is after the laser. And I have taken few pictures and sent across with the smartphone to a few of my colleagues in cases where I had a dilemma regarding how to manage. And it was the advices I got through them were very fruitful in giving a good outcome to the patient. So this is a good area where the teleophthalmological part, which I stress upon. You can also take stereo photographs. If you can do a physiological diplopia by converging, the third image in the center will give you a 3D picture with the occludex floating in front of the retina. So this is by slightly offsetting the angle of the image, angle of the phone, and getting the picture. This is another case with the choroidal lapsus. If you get the 3D image, you can see the elevation, you can see the cystomacular edema, and also fine striae from this area. Now, Dr. Shanmugam's paper also mentions about direct ophthalmoscopic documentation using an LED lamp. I don't have any experience with that. Maybe you can check it up. You need an additional attachment like this to the back of the cover with a 9-volt battery. Now, going ahead with what other people are doing, they've added an adapter called the PEAK adapter by this PEAK Vision group, which are a group of ophthalmic investigators trying to look at how to take ophthalmology to the masses in the depth of Africa, where they don't have many facilities. Now, they have a volunteer carrying this to different parts of Africa and documenting these changes and sending it into a cloud computer where a consultant would see and decide on what to do. So that is teleophthalmology taken to the extremes with the smartphone. There's also adapters which are made of using a 3D printer. This holds the indirect lens. So if you're not comfortable, so it's a little difficult thing. So if you're not comfortable, you can put the lens on this, put this onto the phone and take pictures as, and it'll be a little more steadier kind of a technique. Now the pan-optic fundus ophthalmoscope from Welsh-Allyn has come up with this back cover attachment to an iPhone with an iPhone app, which is designed for this. So you can take pictures of the like a direct ophthalmoscope, and you can have a real good documentation with the database. One also has surprised that they have miniaturized the fundus camera and attached it to the iPhone, and this attachment comes around $800-900, the iPhone excluded. And these are the pictures, and this really gives a run for the money for the fundus cameras. Almost the same kind of comparison. They call it the cell scope. And the images are very good. Now, our own in Bangalore, like Dr. Shishmila was mentioning, the Remedio group, Mr. Anand and group have patented a technology where you can have the similar kind of thing. It's a Micromax 8 megapixels camera, and it gives you a very good picture. And as she showed, you can either mount it on your own slit lamp by moving the optics away, or you can use it in a handheld fashion, like this. So this is the way it is done. And you can see the clear images. It's as good as having a good photography system, integrated photography system. Now for some fun part, you can use a retina selfie, get a retina selfie. You know, this is not my technique. I just found it when I was looking out, and this person called Enric, a second-year student in optometry, has done it. What you need additionally is a mirror to focus, see the image and align it. So I have tried it, and let us see how it goes. This is the video mode with the bulb on, and you are facing the camera like this. My pupil is dilated, and interpose the 28 diopter lens and turn on the camera, monitor the image on the mirror. So you can get the picture there. So that's I don't take credit for it. It's Enric's idea. I found it very amusing also when I saw it. So you can see a PED. I was surprised I have a PED in my eye. So yeah. So that's fine. I need to do an OCT, I guess. So I've also zoomed into that image to see that the quality is not too bad when you look at it. I think the video is stuck. All right, not going further. Okay, that's fine. So I mean, aside the fun part, I thought there's more to it. You could actually look at it as an attachment to the phone to give it to a diabetic who could, if you could do a smartphone fundoscopy selfie and send it across to a consultant. You could actually see the image and say what's wrong. And out-of-box idea has come from this. This is a contraption you put it on the eye called the eye mitra. You don't have anything. The patient has to just put it on, and the images come on in the screen. So that's another thing which is. So this is an exciting thing. The fun. So. To conclude, it's a cost-effective method, and the more important role is in teleophthalmology. There is a learning curve. You have to struggle a bit in the initial phase to get the right direction, the right distance. But the newer developments, newer adapters, newer phones, newer technology, I think would make this more exciting and easy and more acceptable to the masses. Thank you very much for your kind attention.
Thank you, Dr. Biju Raju. I think next year we will require a wet lab on taking a retinal selfie from you.